Hello, everyone. We'll get started in just a couple of minutes. Welcome to the CDC Foundation webinar. We see a number of people are still signing in, so we will get started in just a couple of minutes. Well, hello, everyone. Welcome and thank you for attending today's CDC Foundation webinar. This webinar is the sixth in a series and is part of our ongoing work and commitment to support those of you working in communities and partnering with communities to fight this pandemic. I am Dr. Lisa Waddell and will serve as your moderator for today's webinar. Today's webinar will focus on monoclonal antibodies for COVID-19, a life-saving treatment your community should know about. What are monoclonal antibodies? How does the treatment work? Is it available in my community? Who is eligible? Is it free or covered by insurance? Where can I get more information? These are just a few of the questions our speakers will address in today's session. Next slide. We are thrilled to have a number of expert speakers on this topic with us today. As a reminder, the webinar is being recorded. The recording and the slides will be available later in the week on our CDC CBO resources webpage. Next slide. As you can see from this slide, we have a robust agenda. You may access the agenda and the impressive speaker bios from the link that will be in the chat box. Also, please use the Q&A to type in questions. So let's get started. First, we'll hear introductory remarks from Dr. Judy Monroe, who is the president and CEO of the CDC Foundation, and Ms. Larry Kokot, who is the principal and national leader for the Center for Healthcare Regulatory Insight at KPMG. And we also want to thank KPMG for their assistance in planning today's webinar. So I'll turn it now to Dr. Monroe.
Thank you. Good afternoon, everyone. As a former practicing physician in rural Appalachia and a leader responsible for supporting systems of care across an entire state in the past, I am keenly aware of the challenges many patients face in accessing treatment therapies, especially those that may be new and perceived as available to only some. This is why I'm so pleased the CDC Foundation is able to host this discussion today, where important and timely information about a life-saving treatment for COVID-19 will be shared with you. As you all know, we continue to follow the science and make adjustments to inform policy and program decisions. Today, as vaccinations have progressed across the country, we are all feeling more comfortable being around others outside of our homes. I believe that most of us are sensing a growing optimism as our communities return more to normal. The good news is that COVID-19 cases and deaths overall have declined significantly over the past few months. But with so many people not yet vaccinated, we are not out of the woods yet. In fact, the decline in cases and hospitalizations has leveled off, as have vaccinations. And adding to the concern is that we are facing newer and more worrisome COVID variants, including the Delta variant. We cannot rely solely on vaccines because so many people are yet to be vaccinated. So we must bring to bear a whole package of tools. And this includes protective measures like wearing a mask if you're not vaccinated and keeping your physical distance. Taking preventive measures such as getting the highly effective and safe vaccine. Utilizing early intervention approaches such as getting tested if you've been exposed or have symptoms. And if you tested positive, knowing the treatment options that you may be eligible for, such as monoclonal antibodies. It takes the entire system, healthcare providers, payers, testing centers, and yes, community-based organizations, like many of you who are trusted voices for valuable information that communities need and want to know. We look forward to sharing this valuable information about monoclonal antibodies with all of you today. And now I'll turn the mic over to you, Larry.
Thanks, Judy. It's an honor and a pleasure to co-host this timely and important webinar with the CDC Foundation. We're delighted to join with the CDC Foundation and all of you to crush COVID. My name is Larry Kokot. I'm principal of KPMG and the national leader of the Center for Healthcare Regulatory Insight. I'm also the KPMG lead for the Health Equity Initiative, which is a federally sponsored public-private partnership program to help improve health equity by expanding access to monoclonal antibody treatments, or MABs, for high-risk COVID-19 patients in underserved and disadvantaged communities. As part of our program, KPMG is partnering with providers across the country, ranging from large healthcare systems to smaller federally qualified health centers, to sustain, optimize, and expand MAB infusion capabilities. You're going to hear today from representatives from a few of our sites on how they have been able to expand access to MAB treatments for patients in their communities, and how they've worked with community-based organizations to amplify the message about this highly effective treatment to make sure that those most in need in their communities and at highest risk for hospitalization and death from COVID-19 are able to receive the care they need when they get sick with COVID-19. We're truly grateful to these individuals, these remarkable leaders who are improving lives in their communities every day and ensuring that no one gets left behind in this pandemic. But as you know, there's a lot more work we all have to do to achieve this goal in every community. I'm delighted to introduce Dr. John Redd, who's Chief Medical Officer at the Office of the Assistant Secretary for Preparedness and Response, or ASPR, at the U.S. Department of Health and Human Services, who's going to provide an overview of what MABs treatments are and what community-based organizations should know about them. Thanks again for joining us today. Dr. Redd, over to you.
Thanks very much, Larry, and good afternoon, everyone. I'm really honored to be here on behalf of ASPR, and I'm particularly delighted to be speaking at a CDC Foundation webinar. It's an organization I've been working with for decades now, and I wanted to first set the stage for looking at monoclonal antibodies for COVID-19 and how they fit in to our goals for monoclonal antibody treatment and COVID treatment in general. Next slide. So let's start with what monoclonal antibodies are. So COVID-19 monoclonal antibodies, or MABs, they are intended for patients who have mild to moderate COVID-19 disease. You're going to hear that a lot. These are intended for people who are very early in their treatment. And that's exactly why we're so excited to talk to an organization of community-based organizations, because in order to get product to people quickly, we've got to be out in the community. Secondly, monoclonal antibodies are intended for patients who are at risk of developing severe disease, and they're primarily intended to avoid hospitalizations. I'll get into some of that in a moment. It's now very well established that they're much more effective if they're given early, and you'll hear from all the groups today about efforts that we've put in to do this. And here's the thing I really want people to remember. If you give these medicines to someone who is at risk when they're early in their course and an outpatient, you can reduce their risk of hospitalizations by 70%. It's a huge benefit, not just to the patient, but to the whole system in the United States. Next slide. So let's just put these therapies in perspective. If you look at this slide, this categorizes people with COVID all the way from the left side when they're uninfected to the right side where they've been admitted to an ICU. The important thing about this slide is that COVID-19 monoclonal antibodies are intended for very early phase patients. And you can see the three therapeutics there, which is bamlanivimab and etesevimab, made by Lilly. I'll speak about that later. Casirivimab and indevimab, which is made by Regeneron, and sotrovimab, made by GSK Vir. Key thing about this slide is to bear in mind, and you'll see this in the efforts that we'll talk about today, these are for patients who are early. That's the theme. Next slide. So let's talk about what we've done at the United States government to get these products out to where they need to be, which is in people, literally. So our goal from the very beginning of this effort, which started in November, on November 9th, has been to ensure that these products are used in a safe, broad, and equitable fashion. These products were procured by the United States government on behalf of all Americans for use all over the country. And our intention is that they are free, they are widely available, and easily and quickly available to everyone. So in support of those goals, number one, we've been trying very hard to build product understanding and awareness. What we're doing today is part of this. So we've made sure that providers in the United States, who of course are the people who interface with patients, are up to date on the Centers for Medicaid and Medicare Services reimbursement qualifications, the latest therapies, and the patients in whom they're intended, and make sure that patients are aware of treatment options. We unfortunately have found, and you'll see this in some of the discussions today, that we've had knowledge gaps on the part of both providers and patients. Next, we've made efforts to make sure that, sorry, not next slide, next topic, go back one, thanks. Next topic, we provide information on product location. And that's to ensure that providers know to where they should refer their patients. Thirdly, we facilitate product administration. These products are not difficult to administer. They're a simple IV infusion, but there are precautions that providers need to take. And then lastly, we keep track of where they're being used. Next slide, please. So in terms of what we are looking for from you, this is important. Number one, we are very enthusiastic about you promoting awareness of the therapies in your communities. That is by far the most effective way to get this information out there, far more effective than me as a US government person speaking about it. We really would like for you to share as much as you can information about these therapies that are so helpful for patients. We would like you to post information online, and that's for people who are seeking referral to therapy as they're initially infected. We've got to make sure that people know that MABs are out there, and that's in neighborhood apps such as Nextdoor, social media, etc. We also encourage you to host outreach events. Secondly, please understand your local therapeutic scene and where products are located in your community. It's very important because people are going to ask you. And lastly, as you'll see today, we'd like you to please share experiences to support other people who are trying to obtain treatment. It's very important, literally, to get the word out. Next slide. We wanted to put in links today to make sure that you can access our catalogs that help support distribution and administration of these therapies. I really encourage you to go to these links and look at them. The last thing I wanted to say is I wanted to refer directly to some news that we had. It came out just on Friday morning. Is you've heard about the variants in the United States, and there are two variants in particular, which are subsets of the RNA that makes up the SARS-CoV-2 virus. It's a different strain, if you will. There are two important strains that are resistant to one of the two main therapeutics that we've used in monoclonals. And they are resistant to the Lilly product, which is etesevimab and bamlanivimab. Because the level of P1, which is one resistant variant, and B1.351, that combined had gone over approximately 10% in the US. It's up to 12.6%. We have paused further distribution of that product. We're emphasizing that facilities use the product by Regeneron, RegenCove, which is available free, or Sotrovimab by GlaxoSmithKline. So the news was we paused distribution of one of the products on Friday due to the variants. And that's all I have this morning. I look forward to questions later. Thank you very much. And Dr. Waddell, back to you.
Great. Thank you so much, Dr. Red, for that really important information and certainly specific tips and advice for our community-based organizations. So we just heard the what everyone should know about monoclonal antibodies from you, Dr. Red. So let's hear the why monoclonal antibodies are important directly from the voices of patients. Malcolm?
What really got me was the loss of smell and taste. And that's when I went to get the test for the COVID, and it came back positive. I heard about this procedure. It's called an infusion. I was back to work, back to normal, and it feels great. So if you start feeling ill, get tested. Once you get tested and come back positive for COVID, get this treatment. It's gonna do wonders.
Me acosté, me pusieron la infusión como a las 2 o 3 horas más o menos. Empecé a comer, pero yo ya no sentía la náusea. Pues yo recomiendo a todos que se hagan la prueba del COVID y si salen positivos, busquen ayuda, porque existe mucha ayuda. Ahorita están poniendo una infusión, se llama Monoclonal Antibodies. Es gratuito y les ayuda a salvar su vida. Yo lo hice y de verdad estoy aquí.
She came back and said, "Oh, you have COVID." I said, "Oh my," wasn't feeling all that great. And I was contacted by, I believe, Jenny from Laurel Hospital. And she asked me, would I be interested in taking the infusion? And I said, yes. Once I had the infusion, I've been feeling really wonderful ever since. I recommend this to everyone. I am now on the phone daily talking to my friends, and it really works.
It's really important that we as faith leaders, and me being a voice of this station, being the voice of Christian radio in our market, to really be able to give the facts. There's a treatment called the monoclonal antibodies that you can get to help you get through your process of COVID-19 a lot easier. I had COVID-19 along with my daughter and my husband. Our whole household was quarantined. And to know that something like that is in place after going through what I've gone through is a blessing. You want to make sure you're able to get these antibodies so that you won't be a statistic and your grandmother won't be a statistic, or your mommy or your auntie. Tell the facts, share your platform, show your voice. I believe that I have that responsibility, and I believe you do as well.
Great. Well, hopefully from the video, you could see and hear the impact of receiving monoclonal antibody treatment had on patients firsthand, and on those that are advocating for the best care for patients. So now that we've actually heard these experiences from patients, let me turn to our first panel to describe how partnerships are facilitating access to monoclonal antibodies in communities. What is the role of health systems? And then following this panel, we'll have a second panel that will dive deeper to describe the role of community-based organizations to increase the awareness and access and facilitating access to this treatment. So first, we're going to hear from Dr. Christian Ramers, who is the Assistant Medical Director for Research and Special Populations with the Family Health Centers, a federally qualified community health center in San Diego, California. And then following Dr. Ramers, we'll hear from Ms. Jane Thornhill, the Vice President with Henry Ford Physician Network and ACO with the Henry Ford Health System in Detroit, Michigan. Both will share insights from a health system's partner's perspective. So Dr. Ramers, over to you.
Thank you so much, Dr. Waddell. And I have to admit it, I got a little choked up seeing that video. It's so nice to see some hope in a year that's been marked with such misery and suffering and death. And that's exactly what we're talking about here is a great treatment that we can offer our patients. And I'm so happy to have the community-based organizations here to share that message with us. Can we go to the next slide, Malcolm? So I intentionally put my email on my cover slide because I wouldn't be here if it wasn't for the ability to reach out to colleagues, specifically St. John's in South Central Los Angeles, who gave us this crazy idea to start doing monoclonals in our underserved communities. So please feel free to reach out if you want to share best practices or just talk about what it's like. Next slide, please. We've done our own humble efforts in San Diego starting in December of last year, really in response to the community need. Our hospitals were being overwhelmed, and as a large federally qualified health center network, we felt like, what can we do in the community? And I consider us a community-based organization to help keep patients out of the hospital. That was our primary objective. Next slide, Malcolm. And as of last week, we've done about 320 of these infusions, originally with bamlanivimab and then the combination, and we've shifted over to casirivimab and imdevimab for reasons that Dr. Red outlined. And we've only had 4 people that had to go in the hospital. That's a rate of 1.25%, and these are high-risk patients where you would expect it to be closer to 10%. By my calculations, this means that based on this page, we've saved about 20 people's lives. And that is why this is so important, that we actually have the potential to make COVID not such a miserable thing for families and patients, but to really make a difference and prevent people from getting sick. Next slide, please. Now, as a clinician, you saw a version of this on Dr. Red's slide. COVID has been very interesting to figure out the timing. And it is a disease more than any that I've ever treated where the timing is absolutely critical. Go to the next slide, Malcolm. So people go from having really clear looking lungs on the left-hand side to having really terrible, what's called ARDS, or being on a ventilator, over to the right-hand side. And the next slide, Malcolm. And the really, really critical time is from the moment somebody starts to develop symptoms for about the next week or so, in that red circle there. This is absolutely critical that people seek testing early. It's absolutely critical that the tests are turned around quickly. It doesn't do any good to take a test and not get the results for a week. And at this moment, it's absolutely critical that there's community awareness and easy referral mechanisms in order to get people into that chair to receive the monoclonals. Go ahead, one slide, Malcolm. I know from being in the community, there are a lot of steps. People are not testing necessarily exactly in the same site where they get the infusions. This is out in the community. This is our clinic in Barrio Logan in San Diego. And it takes people out there spreading the word, getting that test done. Next slide. In our system, the next thing that happens right away, thank goodness we were able to do this due to telemedicine, we get a doctor on the phone right away with that patient to deliver that positive result, talk to them about monoclonals, and talk about the risks and benefits. And then next slide, as fast as we can, get them into that chair and give the treatment. I should say, of those 4 people that needed to go into the hospital, they received their infusion almost at the very end of the 10-day window, days 8, 9, or 10. And maybe if we got to them earlier, we could have kept them out of the hospital. Next slide, please. Now I'm showing you a picture of San Diego, and I feel like I'm speaking to community-based organizations that have seen some of the disparity issues with COVID in our country. San Diego is right up against the Mexico border there, and you can see just by the color and the depth of the green in terms of the case rates that the lower income neighborhoods in the south of San Diego have borne the brunt of COVID. These are mainly Latinx populations, mainly lower income. We go to the next slide. And what we have seen in many cases in medicine is that the interventions that are most needed by populations in need tend to go to the populations that probably need them the least. And this is a concept in social sciences called the inverse equity hypothesis, where a new drug comes out, a new procedure, and who gets it first? It's those in the nicest neighborhoods with the least health problems. So we felt very strongly, we've been doing this work for 50 years in San Diego, of trying to fight against that equity problem and really get those who needed the treatment the most, who were suffering the highest burden of COVID, get this amazing treatment that we had available. And I put a quote up there just from one of my idols, Paul Farmer, an infectious disease doctor from Harvard, who's done work in Haiti and elsewhere, that any serious examination of epidemic disease has always shown that microbes make a preferential option for the poor, but medicine and its practitioners, even in public health, do so all too rarely. So we need the help of community-based organizations like you to increase the awareness and to help. This is a team sport. fighting COVID is certainly not an individual effort. Next slide, please. So I show you on the left something called the CDC Social Vulnerability Index, which has poorer neighborhoods in darker blue and richer neighborhoods in yellow and green. And over on the right-hand side is where these monoclonals first were made available in San Diego. Next slide. And as you can see, the best neighborhoods with the highest income actually had the easiest access to these monoclonals early on. My site is down there on the bottom in Chula Vista, and so we've been doing everything we can to spread the word and make sure that our patients have exactly the same access to this life-saving intervention that those up in the rich neighborhoods do as well. Next slide. So I'll just finish with some final thoughts, early lessons learned about monoclonals. As Dr. Redd mentioned, and as Judy mentioned in the very beginning, this is an underutilized resource, and yet it's the best thing we have, absolutely, for COVID. Once people get into the hospital, they can get steroids, they can get remdesivir, which only take a couple of percentage points off of the mortality ratio. These monoclonals decrease hospitalization by 70 to 80%, far greater than any other thing we have. But awareness is key. It's key to improving availability and uptake. Some people don't want to take these because they don't even understand them. They don't know what they are. So we need your help to spread the word. As I've mentioned in that timeline slide, we also need very tight integration between testing, telemedicine, linkage to care, and that requires community involvement and high levels of collaboration that are rarely seen in our fragmented healthcare system. So the call to action to you before I turn it over to Jane is that you need to help get the word out. We need more community awareness. This has been one of the unsung heroes of the COVID-19 pandemic. Anyone involved in community outreach or testing must be aware of these local resources. Hopefully we'll give you those websites to find the local monoclonal clinics near you. And finally, if we succeed in increasing awareness and increasing availability, this will save lives. By my own calculations, we've saved over 20 people's lives in our own clinic. So thank you so much for your attention. I'm very happy to be here, and I'll pass it now off to Jane Thornhill.
Thank you, Dr. Ramers. Appreciate the information you shared. Much of what you just stated resonates for us here in Southeastern Michigan and Henry Ford. Good afternoon. As stated before, my name is Jane Thornhill. I am the Vice President of Henry Ford Physician Network and Accountable Care Organization. I am not a clinician. I'm an operator, and so I was able to be brought in very early on a conversation that was had that was facilitated by Larry Kokot, KPMG, with the executive leadership at Henry Ford Health System, and talking about the need. We here in Southeastern Michigan were experiencing another significant rise in cases in late March and early April. And as for any of you that were following the news, certainly were hit very hard early on about that same time last year when our COVID case rate was significantly higher. As such, we had a conversation internally with our executive leaders. Myself and my physician partner, Dr. Bruce Muma, were asked to mobilize a MAB clinic offering. And what's important to note is that we already had monoclonal antibody treatment occurring. However, it was happening in addition to regular infusion services. So imagine you cannot be bringing COVID positive patients in with other immunosuppressant patients in an infusion center. So we had to get creative, and we needed to do it fast. And before I move on to the next slide, the thing that was really important, not only did we have passion for taking care of the folks in our community, as we're called to do, we also, as an organization, had been hit hard, as I had stated, on COVID-19 case rates and hospitalizations for over a year. We were really compelled to move as fast as we possibly could to try to help out our colleagues and to keep ED and hospital admissions as much to a minimum as possible. And so we moved very quickly by trying to operationalize internally and then capitalize on our community-based organizations to spread that service and the word. Malcolm, if you could go to the next slide. So what you'll see here is what I was just describing. And so all the way to the left of this slide, you can see in late November, we were performing MAB infusions. But again, this was being done after hours by nurses that were picking up overtime in order to be able to perform this function. In addition to that, our referral process, both internally and externally, was cumbersome. We had over-engineered that process. And when we got involved in it and started to realize we had to simplify this process so that we could make it easy for the people who already were aware, the providers that had already knew the value of MAB and had patients that they were trying to refer, that we could get them into the queue and get them treated. We have, as you can see, based on the thing at the top, where we got involved. And so that is in week like 18, 19 of this particular graph. And you can see that we hit a peak of cases of, almost 250 cases in 1 week. And we've done a total of, this is through, I believe, June 16th. So it's a little stale data, 1,732 infusions. And 1,000 of those are since the Health and Human Services meeting that we had, where we were asked to really up our opportunity to deliver this infusion and very important treatment. Based on our calculations, we've avoided 173 hospitalizations and 35 deaths. This is significant. Think about the lives that this has touched. And we have collected data. I will say we were moving so quickly. We are going back now with our research division and combing through our EPIC data to make sure that we can report even more robustly on who received this treatment. Back to what Dr. Ramers just said, right? What can oftentimes happen is we're not reaching the communities in need. And so as we started to take a look at this, we were collecting information regarding race and ethnicity, gender, and age, but there is more information that's available to us, and that is happening in a retrospective perspective, a retrospective effort. What I will say is that we realized very quickly that, again, we had to change our processes, and we needed to utilize resources in a centralized environment. And what you're going to hear in a little while is from Dr. Felix Valbuena, who is Henry Ford Health System's federally qualified health center partner in Southwest Detroit. And he became a huge asset to what we were trying to accomplish. And so our decision, as I stated, was to mobilize early. We could create more opportunity within our own healthcare system faster than we could by trying to create stand-up clinics within the community. And so that was a decision that we made. We took a look at the internal data at Henry Ford Health System. We were testing 2,000 patients a day. We had over 500 patients coming back testing positive when we stepped into this role. So we knew that if we could get them into the centers that we already had and we were expanding, that would mean that we were able to get them within the window of time for treatment, as Dr. Ramers just displayed in his graphics. And we were able to did that in Macomb County, Wayne County, and also in a central county within Michigan, which Jackson County, forgive me, all of a sudden I just forgot the name of it. We utilized mid-level providers to work a queue. So everyone testing positive and the basic criteria within our EMR went into that queue, and we were working that queue to get to doing outreach to those patients who were qualified, who tested positive and met minimum criteria for qualification, having conversations with them, educating them about what MAB is. And then if they were willing to receive treatment, we were making arrangements for them to be seen same day, next day. We knew that timing was hugely important here. And if transportation was an issue, we had already partnered with a transportation company that was going to be able to provide that for us. In addition to that, if transportation was not even an option, we had partnered with home health to be able to go and do MAB infusions in a patient's home. We then reached out simultaneously as we were trying to stand up our own internal sites to the federally qualified health centers. Dr. Valbuena was our key to that. He brought together the entire council of leaders of the FQHCs within Southeastern Michigan. We shared with them what we were trying to do. We continued to look at data to determine whether or not we needed to bring forward any additional sites in addition to CHAZ, which you're going to hear about. And simultaneously with that, reaching out to all of the county health medical directors and the City of Detroit Health Authority to provide this information as they were receiving information from the state of Michigan for patients who were testing positive, that these sites were available, how to refer, and that we could get their patients in within 24 hours. And in doing that, we were asked by them, could you give us training and education material? We want to train our contract tracers. And so we developed that information based on CDC guidelines and put that information together for them so that they could get the word out and then with ease of referral, be able to refer their patients to us. Next slide, please, Malcolm. So what we did is we created, and again, I think, you know, I'm an operator. So referral management has been a core portion of my career. And so I'm going to anchor heavily here for a minute. For external providers, and how we determine that is if you're not a Henry Ford Health System sitting on our version of Epic, there was one number answered 24/7 where you could call and refer a patient. We also made it very easy to put in an order for an Epic provider called MAB Infusion. And so they didn't have to go through and answer a ton of questions, and it would flow through to what we used as a slicer dicer tool in Epic to be able to create that work queue. We had a patient out, then we did patient outreach. So the people who were working that queue were reaching out to patients on that report. We also created some patient-facing information, and we had a direct line where patients could call in and receive information. It was a voicemail message that said, what is MAB? Who qualifies? If you believe you qualify and you don't have a provider who can put in a referral, press 3, and it was forwarded to what we call the hub, which was basically a central location to try to schedule these patients across all of our sites. And then, you know, the Southeastern Michigan healthcare departments, we did all of that education with their contact tracers, and we reached out to the community healthcare organizations as well. So that MAB Infusion Hub really drove a lot of the information. The sites in blue were existing. The yellow sites were the new ones that we had developed in order to be able to make sure that we had the patient volume. What I will say in closing is that this is for us to talk about. This is for us to educate everyone we come in contact with. What we hear from patients is, I just didn't know it was available to me. We've also been told by patients that the minute they sit down in that chair and get ready to receive their infusion, they feel better. We had very few people that we had to transfer over to the emergency room and get admitted. Our rate of response in terms of allergic reaction was almost 0. And our partnership with our community organizations has been key for us. Patient-facing education isn't enough. People don't understand this, and we need to be able to talk about what it is in terms that they can understand. I will now pass it back to you, Dr. Waddell.
Great. Thank you so much, Dr. Ramers and Ms. Thornhill. It was great to hear the 2 different models. It was very clear in the remarks that you all have provided the importance of the partnerships and how you both health systems, you know, engaged key partners to facilitate this access and the care in which you have taken to really think through those processes to make sure that people are able to access this important medicine. So thank you again for sharing that information. So now we're going to move to panel number 2, Malcolm. And I'm really pleased to welcome our speakers for the second panel. They're going to focus on how CBOs can improve awareness and access to monoclonal antibodies. We're going to start first with an overview of the program at the Community Health and Social Services Center, CHAS, there in Detroit, that is collaborating with Henry Ford that Ms. Thornhill mentioned. And then we're going to, and that's going to be provided by Dr. Felix Valbuena. And then we're going to hear from Dr. Jane Morgan, who serves as the COVID-19 task force lead at Piedmont Healthcare in Atlanta, Georgia. So Dr. Valbuena, over to you.
Great, thank you so much, Dr. Waddell. So I know in interest of time, I'm going to try and summarize a little bit, but if we could go to the next slide, Malcolm. Good afternoon, everyone. My name is Felix Valbuena. I'm a family physician by training and currently in my 5th year serving as the CEO of Community Health and Social Services Center, more commonly known as CHAS, a federally qualified health center in its 51st year of providing comprehensive primary health and wellness care to the Southwest Detroit community. I want to start by thanking the CDC Foundation and Henry Ford Health System for the opportunity to participate in this very important effort, which provides an additional resource for our community as we work through the COVID-19 pandemic. Next slide, Malcolm, please. Chess Center has served as the pillar of healthcare for the primarily Latinx Southwest Detroit community for 5 decades, not only providing culturally proficient, high-quality medical care to 2-day-old newborns through geriatric patients more than 100 years old, but everyone in between, including more than 700 obstetric patients each year. It is sometimes disheartening to see that after all the years I spent in school training to become a family physician, on my best days in the exam room, I will only impact my patients' overall health and wellness by 20%. But because we are acutely aware that the social determinants of health are the main drivers of health and wellness, Chess Center also provides dental care, integrated behavioral health services, an in-house pharmacy, an intimate partner violence program, WIC program services, outreach and enrollment services for insurance options, community health worker support, complimentary transportation to and from the center for any appointment that you have here, a community education center with a cooking demonstration kitchen, and an indoor walking track for exercise, among other services implemented to decrease barriers to care and improve quality of life. When the pandemic hit, Chess Center was ready to meet the challenge. We quickly implemented CDC guidelines, triaged in-person versus virtual appointments, opened a makeshift daycare in our community education center for employees' children, allowing them to continue coming to work. We implemented and continue drive-through COVID-19 testing and purchased 2 PCR testing machines, which allow for various point-of-care tests, including detection of SARS-CoV-2, influenza A, influenza B, and respiratory syncytial virus, or RSV, from 1 nasopharyngeal sample. Chess Center started receiving the Moderna COVID-19 vaccine on Monday, December 28th, and currently 89% of our 141 employees have been vaccinated, and a total of 7,504 doses have been administered to our community in sessions at the center on Monday through Saturdays, in addition to pop-up vaccine clinics in the community on Saturdays. Chess Center participates in the HRSA CDC Health Center COVID-19 vaccine program and has not had any challenges in securing enough vaccines to meet the demand from the community. The center provides COVID-19 vaccine to anyone that schedules or walks in for the vaccine during business hours. And also, staff has been trained on asking all visitors to the center if they have been vaccinated, offering vaccine education, and most importantly, offering the vaccine during their visit to the center. The 49-year-old partnership between Chess Center and Henry Ford Health System has allowed our community to access specialty care services when needed, including most recently access to monoclonal antibodies to treat COVID-19 implemented at Chess Center. Our non-stress test prenatal care testing room with 3 stations was temporarily converted into the monoclonal antibody infusion clinic, complete with all the necessary equipment and staff to administer the infusions of bamlanivimab and etesevimab. Referrals for MAB are made through our shared EMR, Epic, and scheduled timely as we provide that point of care PCR testing with extremely quick turnaround. Our community almost always prefers to receive culturally proficient care in their community from their trusted resource for health and wellness. We have seen time and time again that adherence to healthcare recommendations is best received and followed if presented by a trusted subject matter expert like Chess Center staff. Chess staff is constantly providing education at the center, recording social media videos on the subject of COVID-19, participating in town halls, radio interviews, television interviews, and print media interviews. We are very grateful to have been given this opportunity to add one more resource for our services to the community to help navigate through this pandemic, and are looking forward to getting back to some semblance of normalcy soon. Thank you. And I will pass it on to Dr. Jane Morgan, who's the Clinical Director, COVID-19 Task Force Lead for Piedmont Healthcare in Atlanta.
Thank you, Dr. Valbuena. What a great webinar we're having today. You know, when we look at really the scope of where we are in this COVID pandemic, we have seen nothing like it before, certainly with regard to the entire scientific community galvanizing behind a singular entity and sharing information and freely sharing that information, including sharing patents. These are the types of things that we haven't seen before, as everybody leaned in really to preserve life and to save life, and we really truly understood that. One of the things that I think has been very clear is in this pandemic, and there will be many lessons learned when we get to the other side of this, is that we really lacked a framework for how do we really care for our entire community. What is that framework? And oftentimes when therapies become available, not just in this pandemic, but in outside the pandemic, we see it in a centralized area, in areas of our large medical communities, our large medical facilities. And we need to begin to move towards, what does that decentralization process look like? How do we begin to meet our community where they live, where they work, where they play, where they interact, as opposed to having people come to us? And what exactly does that look like in that model? And I think COVID pandemic is demonstrating that for us. Currently, we have about 482 counties in the United States that have a vaccination rate of less than 25%. As we see this Delta variant continuing to take hold, 10% of all COVID positive cases at the beginning of the month were responsible for this Delta mutation. As of today, 30% of those cases are now because of this Delta variant. We also have the Delta Plus variant. We see now that this particular mutation is proving itself to be quite fit. And what is that going to mean? And what is this going to be in our next challenge? We've seen the cases of COVID dropping steadily over the last few weeks, and yet they have not returned to zero. In fact, they have plateaued and are quietly, ever so slowly climbing. And what that generally heralds is that we need to brace ourselves for this next surge that surely will come. And so these monoclonal antibodies are a clear therapy for how we can hopefully get to the other side of this. Certainly, we need to make certain that when we are providing education, we stress that monoclonal antibodies are not a choice instead of public health measures. So you do not have to follow public health measures because we have these life-saving therapies available to you. But we do need to make certain that that information is available. Black and brown communities, by and large, do not have warm relationships with our healthcare systems. Those relationships are somewhat tepid. And then when you bring in research as well, that relationship is almost non-existent. So this cultural concordance and cultural congruence of physicians and other providers who are speaking to all community and all potential patients is incredibly, incredibly important, because behind that is also the trust factor. The other thing that we need to think about as well are the regional differences. There are going to be not only racial differences, but regional differences. And certainly we've got Alabama, Mississippi, Louisiana, Tennessee, Arkansas, and Georgia. And Wyoming is also included in that, although not in the Southeast, really kind of rounding out the bottom 6 or 7 states as far as vaccination rates. Embarrassingly so, since the CDC is housed here in Georgia where I live, and our full immunization rate is 35%. So I think we can begin to predict where we will see these next pockets as we've been able to achieve community immunity, but not herd immunity. And then those pockets of relatively low vaccination will form the nidus of where we can begin to see these new mutations develop and perhaps begin to challenge the immunization status of the rest of us. So these monoclonal antibody therapies are going to be important as we go into this next surge, much more so than it has been previously. And we need to ensure that that information is available and that these therapies are available to everyone, including home health care. And that information, most people have not heard of monoclonal antibodies. It's sort of a complicated word if you're not in science. People don't really know what it is or what it means. And I think we need to begin to sort of demystify that when we have our conversations and move it forward. And so health literacy is going to be important, building these trusting relationships, mitigating the barriers, understanding what those barriers are with travel and cost, cultural concordance, and understanding as well that it's not a substitute when we're delivering this message for public health measures, for masking, for getting a vaccine. It is in the instance that you do become positive and develop some symptoms to keep you from becoming very ill. And so it's very important to make certain that we deliver that message in a very responsible way, such that people don't feel emboldened to eschew public health measures in lieu of life-saving therapy that's available. And now I will pass it on to Dr. Waddell. Back to her.
Great. Thank you. Thank you. Thank you so much to you, Dr. Morgan, and to Dr. Valbuena. We really appreciate you all's remarks and most importantly, what you are doing to provide service to those in communities. So now we're going to bring all of our panelists, our speakers, back on, and we're going to engage in a short question and answer period. We certainly have had a number of questions coming in, and some responses are being provided there in the chat. But as we get our speakers back on, we want to certainly encourage all of you to, click on the links and to access these great resources that are being provided. So let's get started here. I think I will direct this question to Dr. Ramers, but we're getting a number of questions around if you could just describe, provide just a short summary of what it is this treatment actually does, and what makes it work, something that those that are representing community-based organizations could use to explain it to others. Could you give us a short summary of just how it works?
Sure, I'll start with the scientific explanation, and then I'll give you an example I think might even stick a little better. So what these antibodies are really modeled after proteins that we all have in our bodies that protect us from every virus that we've seen. It's one of the ways the immune system protects you from getting reinfected. And what the makers of these have done is just really use that knowledge to make them directed specifically against the SARS-CoV-2 virus that causes COVID-19, specifically on those spike proteins on the outside, and it just blocks them from entering more of your cells. That's why it's so critical to give early on, is because you want to stop it from infecting more cells. And the simple analogy for me is if you're a quarterback and you're dropping back in the pocket, you want to have a good offensive lineman to just block that hungry defensive lineman from sacking you. That's what the monoclonals are doing. They are just blocking entry and preventing that virus from infecting more of your cells.
That's great, fantastic. And certainly you also commented about it's a team sport, so love the sports analogies that folks can really relate to. So another question, and perhaps Dr. Valbuena, you might be able to address this one from your experience, or Ms. Thornhill. What can we do for those who do not have a primary care doctor, or for those who don't have insurance and yet they have tested positive and need this therapy?
So I can start by saying that about 40% of our 12,000 unduplicated users, as the Bureau of Primary Health Care refers to them, do not have coverage for many of the services. They only have emergency services, only Medicaid coverage. Fortunately, all of the COVID-related services, so the testing, the vaccine, as well as the monoclonal antibody infusions, are completely free for individuals that come to the center. And so cost is never an issue. And for most of our services, because of us being an FQHC, we function on a sliding fee scale, and we can't turn anybody away. So we're able to provide the services that we deliver to the community without cost being an issue, and specifically with the monoclonal antibody infusions, it is free of cost. There is no charge to patients that come for that.
And I can add for patients who do not have a primary care physician or provider to write the order, that is why we put together patient-facing access options, telephone lines, websites, and so based on proof of positivity, and what we said is if they indicate, we were not waiting for a test result to be provided, if they indicate that they tested positive and met the time frame and other criteria for qualification, that our mid-level providers would put in that order for them and then get them scheduled for MAB infusion. So we were, if they did not have a provider, that was not going to be a barrier to care.
Great, thank you. So we certainly have learned through the early part of the pandemic with testing challenges, and then certainly with vaccinations, the importance of having points of access truly in communities. And therefore, some strategies have had to change. We've had to do mobile units and those kinds of things in order to really reach many in communities. So can you all speak to, and perhaps I'll direct this to you, Dr. Red, first, and then maybe Dr. Morgan, you can chime in, that if there's not an infusion center close to me, what should I do? How do I find these centers? And then if one's not close to me, what would you recommend?
Well, yeah, thanks, Dr. Waddell. So my first answer to that question is that as you've seen from the diversity of efforts that we're all talking about today, this is what you're seeing today is one big team, all of whom are working on the same goal. We've done very well with getting supplies of the medications. We've gotten over 1 million doses out in the United States. Actually, we're just under 1 million. I'm sorry, I want to be accurate. Of which around 50% have been used. So we've infused around 540,000 of these monoclonal antibodies in the United States. But we want to go farther than that, and that's why you see these efforts today. So the efforts that you can refer to are to the websites. We put the links in the chat. In particular, Crush COVID, Combat COVID, and the phe.gov websites all have links to help people find treatments. But what it really takes to go the last miles to get the medications to the patients are efforts such as you're seeing today.
Yeah, I agree with Dr. Red. You know, one of the things is we still don't have the monoclonal antibodies really deeply out into the communities. So people still will need to make a phone call or go online and figure out where that access is. But certainly groups like the one that's here, you know, all of us today here on this webinar and others are working to resolve that and go deeper and deeper into the community. Currently, however, monoclonal antibodies are not available everywhere and are not distributed evenly. So you will need to find that. You may start with your local physician or simply going online to find out where they are.
Great. Well, thank you all so much for your participation today, and to our speakers for answering the questions. So we have time for just one more quick question. And the question is, and I'll ask you each to maybe just give us one word. If you were sharing one word that to all of our community-based organizations about monoclonal antibodies, what word would you leave each of our, everyone in our audience with? And I'll start with you, Dr. Red.
I would say early. The effort has to be to get these into patients as quickly as possible.
Great. Dr. Valbuena.
Collaboration between all of the stakeholders in accessing this needed treatment.
Dr. Ramers.
I'll say underutilized.
Yes, and we want to definitely increase that. Dr. Morgan.
I would say interrupt. It interrupts the downward trajectory.
Great. And Ms. Thornhill.
Effective. If we're effective, receiving this treatment is highly effective.
Fantastic. I think you summarize all of that, and I'm sure someone could take that and put that into a visual. And I think it sends a very powerful message for all of us as we wrap up today's webinar and move forward with sharing this important message for everyone. Again, I want to thank Dr. Red, Dr. Ramers, Ms. Thornhill, Dr. Valbuena, Dr. Morgan, Dr. Monroe, and Mr. Kocock for being with us today, for taking time to share this valuable information, for helping us to get this important information out to communities to continue to combat COVID, if you will. We want to thank our audience for all of your participation today, and particularly those representing community-based organizations and all of the partners that you work with, state and local public health, and many, many others in the health systems in your communities. Thank you all for what you're doing and for joining us today to learn. So our final sort of call to action as we close, let's keep in mind, first of all, vaccinations are really safe and effective and must remain our priority. We encourage you and everyone in your communities to certainly get vaccinated. Continue to obtain more information about monoclonal antibody treatment and share that with your constituents. One word could be prepared. Be prepared by getting the information, learning it, knowing where the centers are in your communities ahead of time in the event that you or someone that you can help provide this information to needs it. If you're not vaccinated, by all means, continue to please wear a mask and watch your distance. And again, the CDC Foundation remains committed to supporting you and community-based organizations and others that are all working together on this pandemic. There have been many resources shared and links shared, so we invite you to please access those materials. We do have our resources for community-based organizations webpage here at the CDC Foundation at cdcfoundation.org/COVID-19-community-resources. And we will certainly have follow-up information, the webinar, and other materials there. And so again, thank you all for attending. As you log out, please take a moment to complete the brief questionnaire. Your ideas will help us as we plan future webinars and assist us again in providing the support that we want to continue to do with you all together. Our slides will be available. And again, thank you so much for attending today's webinar. We'll see you next time.